Hi, aspirants. So, let us start with the gynecology. The topic for today will be menstrual cycle. Okay, let us first look at the hormones. So, menstrual cycle is normally of 28 days, right? At 14 day or during mid cycle, ovulation takes place. This is called as the follicular phase from day 0 to day 14, and 14 to 28 day onwards is known as the secretory phase, or it is also known as the luteal phase. The hormone of follicular phase is estrogen, which is marked with a white arrow, while the hormone of secretory phase is progesterone, which is marked with a yellow arrow. Let me just put my phone on silent. Okay, right. So the follicular phase, it starts with menstruation and it ends at the LH surge, right? It generally varies, but it typically lasts for 13 days. Then there is an increase in the frequency of GnRH pulse. This is very important, that there is pulsatile release of GnRH. What will it do? This stimulates FSH, which is the follicle stimulating hormones, and FSH leads to the growth of follicles. Right. As the follicles grow in size, it leads to increase in the production of estrogen. As we can see, estrogen is increasing in the follicular phase. Due to increase in estrogen, there is development of straight glands. This is very important. You might be given a histopath image and asked to identify the correct slide in the follicular phase. So, what we need to see are the presence of straight glands. Right. Next, what will be there? Then the secretions will be thin due to the effect of estrogen again. And by the late follicular phase, there will be a dominant follicle. Right, it is generally around 20 mm in size. Also, what happens? The endometrium lining is thick and the cervical mucus becomes stringy. Then, coming to the ovulation, which takes place on 14 days. Actually, not 14 days, the correct term would be n minus 14 days, where n is the cycle length. Right. So, in a typical cycle of 28 days, ovulation takes place at 14 days. Now, what happens is that estrogen is at its peak. So, what will it do? It will give a positive feedback to the pituitary glands to secrete LH, right? While it will inhibit the FSH. What happens that there will be an LH surge, which leads to rupture of ovarian follicle and release of a mature ovum. This ovum travels to the fallopian tube and the fertilization will take place if sperm is also present. Right. The unruptured follicular cells that haven't ruptured, they differentiate into corpus luteum. And this marks the start of the luteal phase or the secretory phase. Right. Now, the corpus luteum can survive without further LH or HCG stimulation for around 10 to 14 days. So, the length of this cycle will also be 14 days. Then there is a change from estrogen to progesterone. Progesterone is the major hormone. Why? Because corpus luteum produces progesterone in majority of amount. What happens as a result? The endometrial lining, it becomes thick and very important. Remember, histopath will show tortuous glands. Right. Under the effect of estrogen, we were having straight glands, while under the effect of progesterone, we will have tortuous gland. Tortuous glands marks the presence of a secretory epithelium. Right. Then, if fertilization does not take place, what will happen? There will be decrease in LH. As a result, there will be decrease in progesterone and estrogen by the corpus luteum. And as the progesterone falls, this is known as withdrawal of progesterone, which is responsible for the menses. Right. So this is our menstrual cycle. In short, let us revise it once again. So it starts with GnRH pulse, stimulating the follicle stimulating hormones. Follicles grow, leading to increase in estrogen. Increase in estrogen leads to the production of straight glands, thin secretions. Then in late follicular phase, there will be selection of a dominant follicle, and the endometrial will be thick and cervix will be stringy. Then what happens? Due to the increase in LH surge take place. Right. This leads to the release of ovum. The unruptured follicles form the corpus luteum, which can survive for around 14 days. They lead to the production of progesterone that causes the secretory epithelium or the endometrial epithelium to have tortuous glands instead of straight glands. Also the endometrial lining is thick. Therefore, remember one more point here, that progesterone acts on estrogen primed epithelium. This is very important. Make this a thumb rule. Right. That if this is the endometrium, right, it has estrogen receptors and it has progesterone receptors. So when estrogen is there, then only progesterone can act. In the absence of estrogen, there will be down regulation of progesterone receptors and progesterone will not be able to act. Hence, it is very important as it will guide the treatment, because if estrogen is already present, then we need to give only progesterone only pills like progestin. While if estrogen is also not there, then we prescribe OCP to the patient, which we will see later. Another important point which is asked in the exam is the time duration between estrogen peak, LH surge, and ovulation. So the time from estrogen peak to LH surge is 12 to 24 hours, and from LH surge to ovulation is 12 hours. They can also ask the time duration between estrogen peak and ovulation, which is 36 hours. It has been asked in exams before as well. This is the menstruation. Next is the development. So in female development, there are 5 Tanner stages. First is pre-pubertal. There is no hair and in pubes and axillary region, and the chest is flat. Tanner 2 is pubarchy and thylarchy. Pubarchy is the presence of hair, and thylarchy is the formation of breast parts. Then in subsequent stages, there is coarsening of pubic hair and enlargement of breast. And finally, in stage 5, there is adult breast contour and coarse hair across the pubes and the thigh. This is in female, right? Normal male development I'm sorry, my dog is also barking. In normal male development, there is first testicular enlargement, right? Then there is penile growth, which is followed by pubarchy, and then facial hair is there, right? Sorry again for my bad writing. While in females, we saw that there is pubarchy, then thilarchy, okay? And here first is testicular enlargement, then pubarchy. Like in females, hair will come first, and in males, hair will come later. Okay. Next hormonal condition, let's talk about menopause. So, menopause is the absence of menses for a period of at least 12 months. And why this happens? Because there is follicular depletion. As we know that every female is born with a fixed set of follicles, and when there are no follicle, and each every month follicle is being atrophied, and when all these follicle undergo atresia, there is follicular depletion, which leads to menopause. The average age of menopause is 51 years, while in India it is 49 years. How is it characterized? Like the clinical features. So, the most common clinical feature will be hot flashes, right? Then there can be other clinical features like pruritus and vaginal dryness as well, because there is atrophy of the vaginal epithelium. Then the female might also be irritable, and there will be mood swings, loss of libido. Very important point is premature menopause, right? Premature menopause is defined as cessation of menses before 40 years of age. Remember, this is an indication for HRT. There are very few indications for HRT. Now we don't give HRT to all the menopausal, postmenopausal females because of risk of cancer. Therefore, remember this point. Then how will we diagnose menopause? Right. There will be increase in FSH followed by increase in LH. And for treatment, HRT is given. What is the indication? Only when there is hot flashes present which hamper the daily activities, right? Because as you know, excess of HRT may lead to increase in the incidence of breast cancer. Also, there is risk of cardiovascular morbidity and mortality with long-term use and high dose. Therefore, it is not given to every female. Very important to know contraindications of HRT. Very important topic. Okay. First is vaginal bleed. Next is breast cancer. Fine. Untreated endometrial cancer. Then history of thromboembolism. Chronic liver disease. And increased triglycerides. Right? Apart from HRT, what else can be prescribed? We can give SSRIs and SNRIs, clonidipine, gabapentin. They also have shown to reduce the frequency of hot flashes. Then, if there is vaginal atrophy, for that we prescribe topical estrogen creams, right? And another complaint is osteoporosis. Now, osteoporosis needs to be treated, And the drug of choice for osteoporosis is bisphosphonates. Anyone remembers the investigation of choice? DEXA scan. One more question on osteoporosis. We'll do this in ortho, but let's just quickly revise it. What we get? Codfish vertebra and T score less than minus 2.5. Okay, remember T score is not matched and Z score is matched with age. These are all the questions that come in osteoporosis. Fine, let's move ahead to the most important topic, contraceptions. Okay, so this is the table that will solve almost all the questions of contraceptions. And let's get ahead with it. So the first category is those that are more than 99% effective. First is implant. That is, it is a progestin only implant. What is the mechanism of action? It inhibits ovulation. This is asked, right? This is important. And it increases the cervical mucus viscosity. Advantage is that it can be used up to 3 years, right? And it is safe with breastfeeding. What is the disadvantage? Not so much. Irregular periods can be there and scarring at the insertion site. Where is it inserted? So implant is inserted in upper arm, right? So there the female might complain of scarring. Okay, next is IUD. IUD is intrauterine device. Then it can be hormonal IUD or a copper T. Hormonal IUD contains progesterone, which is levonorgestrel. Again, progesterone will lead to cervical mucus thickening and endometrial decidualization. Right. How much it is effective? It is effective for 5 years. The disadvantages are that there might be spotting, okay, and increase risk of perforation. Also, rarely there can be increased risk of ectopics. Next, copper IOD. So the mechanism of action is that copper is a foreign body. So foreign body, it leads to inflammation. Also, copper has spermicidal effect, but the more important point is that it causes inflammation. Okay. Uh, the advantage of copper tea is that it can be used up till 10 years, and the disadvantage is that there is increased cramping, right? And the bleeding is very heavy bleed. Also, there is again risk of perforation and rarely risk of ectopic. Then finally, sterilization, right? What is the advantage? That it is a permanent method. And this question was asked in November INICT, like the current one. Which of the following is not a temporary method? Okay, it was asked LARC, something like that. Reversible contraception. So the answer was sterilization. And what is the disadvantage? Is that again it is irreversible, right? There is increased risk of ectopic, right? Remember a point with this: in males we do vasectomy, right? And most failures are a result of not waiting for 2 negative semen samples. What does this mean? That after vasectomy there should be 2 negative semen samples. If you do not do these, there are chances of contraception failure. Coming to the second category, which have effectiveness in between 90 to 99%. The first one is medroxyprogesterone acetate. Right, it is an IM injection of progestin. What it does is, again, it suppresses ovulation and causes decidualization of endometrium. What is decidualization of endometrium? Remember, in pregnancy we read about the terms decidua. Decidua is a pregnant endometrium. That is the secretory endometrium, or the endometrium which is a thick endometrium under the influence of progesterone. What are the advantages? That the periods will be light and it works for 3 months. Disadvantages are irregular bleed, there are chances of weight gain, then decreased bone mineral density, and there can be delayed fertility up till 10 months after discontinuing the MPA. Right. Next is transdermal patch. It is also known as the patch. Right. So it is combined weekly estrogen and progesterone in the form of a dermal patch. Okay, what are the advantages? That it is very predictable. The periods can be predicted, like there will be withdrawal bleed as we predicted. The menses will be light, less painful. Okay, and the advantage is that you just need to take it weekly. Okay, what are the risks? There is risk of thromboembolism, especially if the female is more than 35 years of age, or is a smoker, or inpatient of chronic hypertension. Right. Next is vaginal ring. It is also a combined low dose progestin plus estrogen ring. It makes the period regular and can be placed intravaginally for 3 weeks, then removed for 1 week, and menses will occur once you remove this. Right, and one more advantage is that it is safe even when used continuously. Okay, the disadvantage is that since it's a ring, it increases vaginal discharge. There is spotting in the first 2 months. There is also risk of thromboembolism. Again, in smokers, female more than 35 years, and patients of chronic hypertension. OCPs. These are the most widely used method of contraception apart from the barrier method. Then what it does is that it inhibits FSH and LH, thereby leading to decreased ovulation, cervical mucus thickening, and again decidualization of endometrium. Why? Because it contains progesterone and estrogen is also there. The advantage is that there is decreased risk of ovarian and endometrial cancers. Again, menses are predictable, lighter, less painful. And the disadvantage is that compliance, because you need to take these pills daily, right? Like you take it for 21 days, then you take a break, and you again continue. So daily you need to take the pills, hence somewhat it is dependent upon the patient compliance. Then there can be incidents of breakthrough bleeding. What is breakthrough bleeding? That is bleeding in between the cycle. Then again, risk of thromboembolism. Then it cannot be used in patients who have migraine with aura. Slightly off topic. Migraine is of two types: common and classical. Right. So the common migraine is without aura, and the classical is with aura. Then it can also be familial, like the familial hemiplegic migraine. Right, we'll do this in neuro. Then, lastly, in this group, we have progesterone only pills. They are also called mini pills, and the action is thickening of cervical mucus. It is safe in females who are breastfeeding, but again, the disadvantage is compliance because it is also administered daily. Right. Then the next group having efficacy between 75 to 90%, they are usually the barrier methods. And the first is condom. Everyone knows that condom is a latex sheet that covers the male genital organ, penis, and the it is the only method. This is a very important question. This is the only method that effectively protects against STDs and HIV. This question has been asked in one form or the other many times. It is a repeat PYQ. Okay, that condom can prevent from STD and HIV, and no other method, even female condom and diaphragm, they are subset to protect against some STDs, but not all, and especially HIV. Only condom is protective against it. Right. The disadvantage is that there can be allergy to latex. Hmm. Then diaphragm, it is usually with a spermicide, and it is inserted over the cervix and prevents the entry of the sperm. Then again, it must be fitted properly. That is a disadvantage. In female condom, it is a barrier sheet that is inserted into the vagina, and the disadvantage is that it is difficult to use. Then natural methods, they are also known as fertility awareness methods. Right. So what is done is that the intercourse is usually avoided during those days of the cycle in which ovulation is likely to occur. That is day 10 to 17. Right. So if this is the cycle, we know ovulation generally happens here. So 4 days before and 3 days after, we take this as the unsafe period. This is the calendar method, and this is also known as the natural method or fertility awareness method. There are no side effects, and what is the disadvantage is that it requires partner participation, and there is no STD prevention, right? Obviously. Finally, the last group that has effectiveness between 68 to 74%, they're very less effective, and they're not used, is first is the withdrawal method, where the male partner withdraws the penis just before ejaculation. Again, no side effects, and disadvantages, again, it does not protect against any STD. And spermicide, as the name suggests, it is a substance that inhibits sperm motility. It can be used as a secondary method in combination with any of the above methods, and these two, they are not recommended as primary methods of contraception. All right. Then contraindications to contraceptives are again a very important topic. I cannot stress upon its importance anymore. Right. So first, let's talk about estrogen containing hormonal methods. What are the contraindications? So first is history of stroke, hypertension, and TVT. That is why we were reading the disadvantages that in the OCPs there is, or the progestins, there is risk of thromboembolism, right, in female more than 35 years old or a chronic hypertensive female. Then there is risk of, they're contraindicated in patients of breast cancer, undiagnosed vaginal bleed, then estrogen dependent cancers, hmm, liver neoplasms, benign or malignant both, or an abnormal LFT, then more than 35 years of age, or if the female is a smoker, and migraine with aura. We've already discussed all these points and they are very important to remember. What are the contraindications to IUD? Both progesterone and copper containing. Again, severe, sorry, uterine structural abnormality, because it will prevent the insertion of the IUD, any suspected pregnancy, then any active infection. Now, what is the time period within which it is not inserted? So, within 3 months of infection or any active infection, we do not insert any foreign body inside the uterus, as it will only complicate matters. Then, unexplained vaginal bleed or uterine bleed, then suspected gynecological malignancies, right? Then some contraindications of copper T alone. Let me write it here. So copper T cannot be used in copper intolerance, like a patient of Wilson's disease. So what will they do? They will not ask directly. They will give you a scenario where the patient has decreased copper ceruloplasmin, has decreased serum ceruloplasmin, increased copper, Kaiser-Fleschner ring in the eye, and then they will say which method will you not use in this patient. So here the answer will be copper T. Obviously, it's a very direct question. And in patients with severe dysmenorrhea, we will do dysmenorrhea. Right now, it is of two types, primary and secondary, or menorrhagia. Right. Then indications of the progesterone IUD: if there is any allergy to levonorgestrel, breast cancer, and active liver disease, or liver neoplasms. Then the final topic in contraception is emergency contraceptives. So there are morning after pills, which are known as progesterone agonist and antagonist. Right. So they do not disrupt any embryo post implantation, and they're safe for all women and they're very effective. Right. The disadvantages is that it is not over the counter drug. You need prescription from obs gynae. Right. Next is OCP. So they are beneficial for those women who are already taking OCPs and have it at home. The disadvantage is that there can be side effects of OCP like nausea, vomiting, fatigue. Right. Next is progesterone only pill, and then copper IUD. This is 99% effective, and it can be used up till 5 days of coitus. This is question that is very important and is asked everywhere. The disadvantage of copper T is that yeah, there is involvement of insertion, right? So there is initial cost. Then you need to go to a doctor. There might not be any protection against STDs. So Yeah, some books also say that it can be used up to 7 days, right? And this can be used up till 120 hours of unprotected coitus. One more is there, ulipristal. That can also be used as emergency contraceptive pills. All right, let's move to the next topic, which is amenorrhea. So, amenorrhea is defined as absence of menses up till 15 years of age if secondary sexual characteristics are not present, or 13 years of age, sorry, 15 years of age if secondary sexual characteristics are present, or 13 years of age without the presence of secondary sexual characteristics. All right, so if a female presents with the absence of secondary sexual characteristics, it means that there is no estrogen, because estrogen is responsible for the production of secondary sexual characteristics. Right. So, what can be the causes? Let's just enumerate: primary ovarian insufficiency, and this is the most common cause. Um, this is seen with X45XO, which is Turner's. Very good. Turner's syndrome. The patient will show webbed neck, streaked gonads, low posterior hairline, etc. Then central hypogonadism. Hypogonadism. Then there can be many causes for this, which can be Kalman syndrome, where there is a migration defect and the patient suffers from amenorrhea with anosmia, that is, cannot smell. Right. There can be CNS tumors like galactoria or pituitary adenoma, prolactinoma basically. Then it can also be seen in states of constitutional delay and undernutrition. Right. Then, if the secondary sexual characteristics are present, this indicates that estrogen production is normal, but there are other anomalies which can either be anatomic or genetic. And the etiologies includes Mullerian agenesis, imperforate hymen, and androgen insensitivity syndrome. Hmm. Let us look at the etiologies in bit detail. Right. So we have the hormones GnRH, LHFSH, estrogen, progesterone. First, in constitutional delay, everything will be low, and the reason is that puberty has not started. Right. Second is hypogonadotrophic hypogonadism. Here, everything will be again low because it is hypogonadotrophic. GnRH is low, which will lead to low LH, FSH, and low estrogen and progesterone. I'm so sorry. Just give it a minute or two to load. Right. The etiology can be any hypothalamic or a pituitary cause, or it can be due to low caloric intake. Right, you know the hormones, right? If suppose let's draw hypothalamus pituitary gonads, like ovary. So hypothalamus secretes GnRH, which stimulates the pituitary to secrete LH and FSH, which stimulate the gonads to secrete estrogen and progesterone, and these have a negative feedback on these hormones, right? So if GnRH is low, then everything will be low, which is clear from this diagram, right? So this is known as hypogonadotrophic. Hypogonadotrophic means GnRH is low, and due to low GnRH, the gonads will be small. So hypogonadotrophic, hypogonadism, everything will be low again. Next, hypergonadotrophic hypogonadism. Here, what will happen? GnRH will be more. As a result, LH, FSH will be more. Right. But here we will see that estrogen is less. Why this is happening? This is high, this is high, but this is not high. This means there is some problem at the level of the ovaries. Right. So ovaries are not able to produce estrogen, due to which there is loss of negative feedback, and this causes increase in GnRH and increase in LH and FSH. So here there is ovarian failure. Next is anovulatory problem. So here what happens is that there is problem with estrogen receptor, right? Or the hypothalamic pituitary axis is immature, like prepubertal. So here what will happen? Estrogen will be high, but it will not be acting on its receptor. But these hormones, LH, FSH, they will be normal, while GnRH can be increased or decreased depending upon the condition. In case of prepubertal states or hypothalamic pituitary immaturity, GnRH will be low, while in case of problems with estrogen receptor, the GnRH will be high. And final etiology is any anatomic disruption. Here, since there is problem with the anatomy, तो hormones तो सारे normal होंगे. What is the reason? Menstrual blood, suppose, is not able to come out, or due to any anatomical problem, like this is uterus, vagina. So the hymen is not imperforate hymen. So all the blood will collect here. Right. So these are the basic etiologies of primary amenorrhea. Now let us revise this in the form of this beautiful diagnostic workup. So patient will come with amenorrhea. Then what do we need to do? We need to take proper history, conduct a physical examination, and then we see whether the secondary sexual characteristics are present or absent. Right. As we discussed, if it is present, this means estrogen is normal. If it absents, this means there is some problem with the estrogen. Right. So if secondary sexual characteristics are present, like estrogen is normal, we look at the uterus. If uterus is present, then we look at the presence, then we look at whether there is any obstruction in the outflow of menses. If we can see any outflow obstruction, the diagnosis is very easy. Imperforate hymen. While if there is no outflow obstruction, we can evaluate as we evaluate for secondary amenorrhea, because here we cannot find any pathology in the patient. If uterus is not seen in this patient, then we go in for a calotype analysis. If it comes to 46XY, we label it as androgen insensitivity syndrome, and 46SS, this is Mullerian agenesis. Okay. Coming to, excuse me, let me have a sip of water. Coming to the absence of secondary sexual characteristics, like This indicates to a hormonal problem. So what we will do, we will look at hormones like FSH and LH. If FSH and LH are also low, what does this mean? Low estrogen, low FSH, LH, right? This indicates to hypogonadotropic hypogonadism. And for this, the treatment will be to give estrogen progesterone after 12 to 18 months. But if the hormones, if the FSH and LH are high, then this is hypergonadotropic hypogonadism. In this, we will do the karyotype. Right, if it is 46XO, diagnosis is easy. This is Turner's. 46XX, this is premature ovarian failure. And if it is 46XY, this is partial androgen insensitivity or Swyer syndrome. This table, like this flashcard or this approach, is very important. Please take a screenshot, or my advice is to make it yourself, right, by filling in the blanks like I did, and see if you can answer the question. This is very important, and one question is bound to come upon the workup of primary amenorrhea. Right? Let's move on to secondary amenorrhea. Now, what is secondary amenorrhea? Secondary amenorrhea is the absence of menses for 6 consecutive months, right? In women who already have had their menses. So what can be the etiology for this? The first thing that comes to anyone's mind will be pregnancy. So first, if a patient comes with amenorrhea, whether it is primary or secondary, we will always do a UPT first. Then only we'll go to this diagnostic approach, even in primary amenorrhea and in secondary amenorrhea. Right. Other causes can be obesity, because we know a syndrome associated with it, PCOS. Then there can be problems in the hypothalamus, pituitary, like adenomas or neoplasms, diabetes mellitus, right? There can be problem with the thyroid gland, all the endocrine problems. And then finally with uterus, there can be Asherman syndrome or cervical stenosis. Right, these are all the causes. Let me move them from here. Yeah, so these are the etiologies. Let us look at the diagnostic workup, and this chart is sufficient to know secondary amenorrhea, right? So what do we do when a patient comes with secondary amenorrhea after ruling out pregnancy? We give her progesterone. We do a progestin challenge test, and then we see if there is any withdrawal bleed present. If withdrawal bleed is present, then we'll see LH. If LH is increased, then this is PCOS, right? If LH is decreased, then this is idiopathic anovulation. So, if after progesterone withdrawal bleed is present, this is an ovulation. If even after progesterone there is still no bleed, we look at the FSH levels. If FSH levels are increased, then this is hypergonadotrophic hypogonadism again, or ovarian failure. Right, but if FSH is decreased, then we give cyclical estrogen and progesterone. Right, first we give progesterone, then we give progesterone plus estrogen. Again we look for withdrawal bleed. Now if she has withdrawal bleed, this means that she has hypogonadotrophic hypogonadism. And if withdrawal bleed is absent, then it means that there is some endometrial or some anatomical problem like Asherman syndrome. Asherman syndrome, let's discuss it here only. Right, What happens in Ashenman syndrome is that there is synechia formation. What happens is that if this is the uterus, right? Suppose some procedure was done like a DNC, this will lead to formation of synechia, and this is known as Asherman syndrome, a common cause of secondary amenorrhea. Remember, Kalman syndrome is associated with primary amenorrhea, and Asherman syndrome is associated with secondary amenorrhea. Right. This was amenorrhea in brief. Are you liking it, guys? If you're liking it, then please give me a like, thumbs up, do comment in the comment section below. Fine. Now, let us do first abnormal uterine bleed. So, let's before talking about the abnormal bleed, what is the norm? What is normal bleeding? Right. So, normal menstrual bleed, it ranges from 2 to 7 days. Hmm? And abnormal, it refers to alteration in either quantity, quality, or frequency. So, for the causes of AUB, there is an abbreviation called as palm coin, where P stands for polyp, A stands for adenomyosis, L is leiomyoma, or we call it as fibroid, right? And M is any malignancy or hyperplasia. Then C is coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. All right. So, let me tell you briefly about this. Like, how will we diagnose this? We do obviously ultrasound, preferably a TVS. And if on ultrasound, suppose this is the uterus, on Doppler we see feeding vessel sign. This is a polyp, right? If the uterus appears to be enlarged and we see heterogeneous myometrium, we also call it as salt and pepper myometrium, and this is adenomyosis. And if we see growth, right, then these are fibroids, which can be either intramural, like this subserosal, like this, and submucosal, like this. Okay. Then any malignancy, and fibroids are well defined, heterogeneous, having a whorled appearance, while malignancy will be irregular. Then these are not anatomical conditions, so we will not be able to make them out on ultrasound, but some other diagnostic approach, right? So, what do we do if a patient comes with AUB? So, the first thing is that again we will do UPT to rule out pregnancy. Then we will do CBC to rule out anemia. We will advise a pap smear to rule out cervical cancer, right? Then we also need to rule out any infection due to gonorrhea or chlamydia, as it can lead to bleeding due to cervicitis. Then thyroid function test and prolactin to rule out hyper or hypothyroidism and hyperprolactinemia. Then platelet count, PT, APTT, right, to see if there is any coagulation disorder, also von Willebrand factor. Then ultrasound, as we saw, for any uterine masses. PCOD can also be seen on ultrasound. What we will see is that the ovary will be enlarged. This is PCOS. We'll study about this. And there will be tiny, tiny follicles in the periphery. This is called as necklace appearance. And what all we get is echogenic stroma. Right. Then, very important is endometrial sampling. So, what is important to know? We've done ultrasound. When we do ultrasound, we get to know the endometrial thickness. Right? Suppose this is the uterus. We will see an echogenic line. Right? We'll place our calipers from this echogenic line to this, and this will give the ET, or the endometrial thickness. If the endometrium is more than 4 mm in postmenopausal, very, very, very important point. Remember this always. Right. Or in a patient who is more than 45 years, still she's having, we go in for biopsy. If the patient is more than 35 years and she has risk factors for endometrial cancer, then we do endometrial biopsy. My pen is about to go. Let me complete this topic. How will we treat this patient? Right. We divide our treatment into four categories. First is acute heavy bleed. Next is ovulatory bleed and anovulatory bleed. Let's talk about these three conditions first. So here we give high dose IV estrogen because this will stabilize the endometrial lining, and this stops the bleeding in 1 hour. Right. Then after that we can give combined oral contraceptive pills or add progestin when the bleeding is stabilized. Suppose if estrogen is contraindicated, right, then we can give high dose progesterone therapy alone. If after 12 to 24 hours the patient is still bleeding, then what do? Dilatation and curettage. If the patient presents with ovulatory bleed or menorrhagia, then we give NSAIDs, Trenexa. Right, it can be given for 5 days during menses, and if the patient is hemodynamically stable, we give OCP and or IUD or progestins. Right. For anovulatory bleed, what is the goal? The goal is to convert the proliferative myometrium into a secretory myometrium. Right, this is the goal, from estrogen to progesterone. So we will give progestins for 10 days. This will stimulate withdrawal bleed. And then we can give OCP. We can also give progestin IUD, levonorgestrel containing IUD. If the medical management fails, no response, then we go in for DNC. We can do hysteroscopy to identify if there are any polyps, right, or if there are any indications to perform biopsy. And we can also undergo, the patient can also undergo, uterine artery embolization if fibroids are the cause of menorrhagia. So let us see the indications for hysterectomy, right? When medical or hormonal treatment fails, when fertility is not desired, and symptomatic anemia, or those who diagnose a disruption in their life quality from the persistent bleed. Right, I'm stopping this. We'll continue in the next part. Okay, so hope you like the video. Do leave a comment and a like. And guys, go and check out my Instagram page. If you want to study something, you can always message me. And yeah, happy learning.